08160
Okay.
86 3328.
Good afternoon, everyone. You are welcome. We just wait a few minutes to get those in the waiting room to come in. Thank you.
Good afternoon, everyone. I want to welcome you to as our custom of IAMRAT. The Institute for Advanced Medical Research and Training was established in 1980 as one of the academic divisions of the College of Medicine, University of Ibadan, primarily for coordination of multidisciplinary research programs in the college. Statistics, cancer research,
Hello, sir.
Hello, everyone. Yeah, we can hear you. Sorry, it's a network issue with the secretary. I will soon come up now. Sorry.
Can you move away from where you are, Dr. Adeliji?
Can you hear me?
Hello.
Hear me now?
We can hear you, but just change your position. Hello. Hello.
Can you hear me now? Hello?
Yes, yes,
Hello?
yes. Go on.
Okay. Sorry for the network issue. I want to welcome you once again to the April edition of IAMRAT lecture series. Let me run you through the background of the institute. The Institute for Advanced Medical Research and Training was established in 1980 as one of the academic division of the College of Medicine to address the limited institutional capacity in Nigeria for strengthening training, research, and policy development in the area of health. This has a track record of excellent research of international standard, channeled towards relevant local and global health problems. This has complement of trained staff with expertise in the following areas of research: malariology, epidemiology, biostatistics, cancer research, drug research, genetics, biology, entomology, molecular biology, science, and aging medicine, to mention few of them, with like World Health Organization, the National Institute of Health, and so on and so forth. And the institute has numerous research and administrative units, among which the following stands out: genetics research, drug research, cancer research unit, malaria research, molecular entomology, neuroscience and aging research unit, epidemiology and statistics research unit, palliative care unit, and domicile in this is the University of Biol School of Hospital Ethics Review Committee, the top research ethics committee that established in year 2002. The institute is headed by director, and the current director is Professor Ikeoluwapo O. Ajayi, and I would like to hand over to her now so that she can make her opening remarks. So Professor Ajayi will come up now for our opening remarks. Thank you very much. Hello, ma'am.
Yes, good afternoon. Thank you very much, Dr. Adeniji. Well, it's unfortunate that the network is playing up, but please bear with us. Thank you very much once again, Dr. Adeniji. I welcome everyone to this April lecture. And I wouldn't say much, I would just want to thank our lecturer, Professor Morhason-Bello, who gladly accepted to deliver this month's lecture. It's a rare privilege to have someone like him come up, because he's into many, many researches and very busy, but he gladly accepted to share one important topic which he's working on, and that's looking at the human papilloma virus and the various diseases that he has a project going on which he shall share with us. Professor Morhason-Bello is also one of us at the Institute for Medical Research and Training. And so we are very glad to have him. To say more about him, Dr. Bakari would give us a brief on his profile. So let me just hand over to Dr. Bakari. Thank you very much, Professor Morhason-Bello. Dr. Bakari, please.
Thank you, ma'am. Yes, good afternoon, ma'am, and good afternoon, everyone. My name is Dr. A.S. Bakari from IAMRAT. I'm to read the citation of Professor Morhason-Bello to everyone. Imran O. Morhason-Bello is a professor of Obstetrics and Gynaecology, College of Medicine, University of Ibadan. A consultant gynecologist at the hospital. He is visiting lecturer that is sexually transmitted infection tract, School of Medicine, London, Research Fellow, Institute for Research and Training, IAMRAT, Research Fellow, National Institute for Medical Research, NIMR, and Adjunct Professional Institute for Cancer Research and Treatment, NICRAT. Graduate of University of Ibadan and holds 2 master's degrees, one in Master of Nephrology from University of Ibadan, a doctoral degree in Clinical Epidemiology from the London School of Hygiene and Tropical Medicine, London, as PhD, Surgeon Fellow of the National Postgraduate Medical College, Faculty of Obstetrics and Gynaecology, FMCOG, and Fellow of the MBBS. Professor Morhason-Bello's clinical research expertise, special interest in genitourinary medicine, gynecological oncology, infectious diseases, health, and with over 250 publications. HPV College of Medicine, University of Ibadan, membership of consortium comprises of clinical scientists and faculty members in clinical science, public health, including science, Cancer Institute, Society, American Association, Commission, and EDCTP Horizon Project, the John R. Flanagan Foundation, USA, Northwestern University, USA, and TED Fund, among others. Some of the ongoing studies cover understanding of the biological, genomic, and epigenetics of the natural history of HPV-associated cancers in the oral, oropharyngeal, cervical, and anal cancers in women with or without HIV infections. Key affected populations are males in the community. In addition, the team is also working on innovative approaches to improve access to cervical cancer screening through implementation science research to test adoption of self-sampling, rapid HPV DNA genotyping, and use of handheld colposcopy to liberalize screening at the primary healthcare setting in Africa. Now, the consortium is collaborating with 13 teaching hospitals spread across Nigeria and institutions in Mali, Kenya, Tanzania, United Kingdom, Catalan Institute of Oncology, Spain, and United States, among others. The journey to HPV research started when Professor Morhason-Bello won the Star Development Grant at the University of Ibadan in 2013 to study Adjunct and Tropical Medicine, UK. The doctoral thesis was titled Epidemiology of and Risk Factors for Congenital and Anal Papillomavirus among children in Ibadan, a mixed method study tagged Shini study. Shini study is the largest epidemiological study in atomic sites. It's for 20,000 people from the general population and high-risk groups to explore the links between different sexual behaviors and HPV infections among adolescents and adults at the community and within the brothels. Professor, also known as Dr. Morhason-Bello, shares with us today the origin, field experience, and lessons learned, as well as policy implications from this unique study. Dr. Morhason-Bello has won several awards, distinctions, and recognitions. Working group, member, National Task Force for Cervical Cancer Elimination for Nigeria, and chairs the Research and Innovation Subcommittee. He led the draft and revisions of several national policy documents and guidelines on women's health, including but not limited to safe motherhood strategy, national and reproductive health policy, national guidelines on pre-eclampsia and postpartum hemorrhage, among others. He has served as consultant to many international organizations, including WHO, UNFPA, Clinton Health Access Initiative, and MSD, amongst others. Professor Morhason-Bello has served on the Medical and Dental Council of Nigerian Decision Board and Tribunal, that is from 2018 to 2022, and currently chair Telemedicine Regulation Draft Committee for the MCGN. He is serving on the editorial board of many journals, including PLOS 1, International Journal of Clinical Practice UK, Global Health and Infectious Diseases, Elion, and Case Reports of Urology. He is dedicated educator and mentor. He has supervised and presently supervising postgraduate and doctoral students at other universities in Nigeria and the Pan-African University and residents in the Department of Obstetrics and Gynaecology. He is an examiner at the West African National Graduate College, Medical College in the Faculty of Obstetrics and Gynaecology. Welcome, Professor Morhason-Bello, as he takes to the stage to present his work for today. Hello, sir, Professor Morhason-Bello.
Good afternoon, Director of Institute for Advanced Medical Research and Training, College of Medicine, University of Ibadan. My teachers and mentors that are seen on that are on this platform, particularly I would like to recognize Professor Isaac Adewale, the former Minister of Health, Professor Akin-Yinka Omibodun, one of our leaders in our department, Professor Mubi, one of the leader in HPV consortium, and my head of department, Professor Akin-Tunde Udukobe. It's a delight to take up this challenge. I know the director of institutes has been encouraging me since last year to give a talk on what we are doing or what I'm doing in one of the small rooms that I was giving. I use that word small, not because the room is small, but because I report there in the morning and I leave sometimes late, or when the security says, oh, there is no light, you have to go. So today I will be talking about sexual behavior and HPV infections. Shini study. I will try as much as possible to provide a chronicle of the science of that study, and then what are the policy implications. So I want to declare up front, please, if you can permit me, I would like to go off because a lot of people may have low bandwidth, and so that they can listen to what I'm talking about. So I have no conflicts of interest. So this is the overview of my talk. I'll give a brief overview of sexual act. I will talk about the synopsis of human papilloma virus. You can't finish everything, but and then of course, why did we embark on Shini study? And then of course, the Shini study. And what are the key findings? We share some public products. The products are still ongoing. I will provide a peep into the emerging science from Shini study. And then of course, I will wrap it up with policy implications, recommendations, and conclusion. So the question I want to put off to start my talk is sexual what? When you are talking to people. Is it sexual fantasy when you have the feeling or erotic sense, or sexual pre-activity, otherwise called foreplay, or sexual contact, or in fact, sexual act? Now, all these we use loosely, and sometimes as either the primary actor, when you are talking about this, we could have different meaning. And if it leads to an health condition, when you are probing it, you also need to know what exactly the person is talking about. So by definition, sexual act is when there is a contact between two or more persons, either by penetration or that is an act. That is if there is penetration. Now, but we know that penetration could be due to genitalia or use of artificial organ or substitutes or even technology. Now, what is sexual touching or contact? Now, there are instances where maybe you are inside a bus and you are standing in a very complex environment and maybe you are touching the next person either in front or behind. Now, will that be defined as sexual contact? Can that also be defined as sexual touching? Now, by definition, it's when there is that contact. Now, the other thing to now associate with it will be, was it associated with satisfaction? Was it also associated with arousal? Now, type of sexual activities can be very diverse. In fact, when I was checking literature for this presentation, there is a difference between health-related classification, psychological or social classification, religious classification, and different classification. But these are the common ones from the scientific perspective. First, it could be based on number of people that are involved. You can engage in sexual activity by yourself, otherwise known as autoeroticism. It could be between two people, and it could also be between group of people, irrespective of orientation or gender. You could also classify it by the method or approach. Was it penetrative, what is otherwise known as intercourse, or non-penetrative, what is otherwise known as outer course? And it could also be due to the personality involved by way of their sexual orientation. We know that in Nigeria, large proportion of us are heterosexual, otherwise known as straight people. It could be between the same sex. It could be between a person engaging in two different sexual orientation. And there are some people that could engage with anybody, otherwise known as pansexuality or omnisexuality. It could also be by way of intention behind the act. Was it associated with erotic or romantic relationship before you engage in that sexual act? Was it transactional? Was it business or for financial gain? So now I will quickly look at the sexual behavior repertoire summarized into penetrative and non-penetrative. The one that we're so much common with is penile vaginal sex. And even our national data is biased towards this. And when somebody said, "Oh, I've had sexual activity," what that person will always think, whether you're a healthcare provider, you're a scientist, you think there's a penetration between the penile shaft and vagina. However, it could also be anogenital, and it could be orogenital. And these two can also depend on the role they were playing. Was that person receiving or is the one inserting? Or was it the person giving or receiving? All this has a health implication. And then, of course, in terms of non-penetrative, the non-penetrative could be in form of masturbation. And you could self-masturbate, you could masturbate mutually with consent with another partner. And that partner can be of the same partner with you, or the same orientation with you, or in the other orientation. And of course, use of sex toy and technology. And it could also be the general feeling of just wanting to touch yourself while your clothes is on, not necessarily bare. That is frottage where you lean on each other and enjoy. And it could also be use of manual activity like use of fingers. So now what is happening is that in the past, when you realize that maybe individuals say, "Oh, 2-3 people had sexual activity with me," we often look at it as an illegal thing, not consensual. But literature is now showing that people do engage in what is called group sex, and this is common among young people. And there are different aspects of it. It could be the female that is center, and then you have more males that are doing, that is what is called gambang. And then, of course, it could be reversed. The man could be the center and could have 3. And that is why I come up with the issue of XOR. And of course, there is also an issue around group sex that is called double penetration. Some people may be penetrating vagina, another person penetrating vagina, and it could be synchronous or serial. And of course, there's what is called monogamous group sex. Orgy is like holding a house party where people is already pre-arranged. And you will say, look, when you get in there, talk to anybody, engage yourself, enjoy yourself. And then, of course, sometimes people could also engage in type of a group sex where they do partner swap. And all these are consensual. In fact, sometimes it's announced before the activity. So when somebody said I've had sex, then you need to really find out what type of sex. Now, in terms of non-penetrative can be exclusive and non-exclusive. It could be non-exclusive in the sense that it's purely non-penetrative. And it could be exclusive, but that means it's non-penetrative. Non-exclusive means it could be a combination of the two. And one of the ones that really comes to mind is BDSM, bondage, dominance, submission, sadomasochism, where one of the partners is either hanged down by way of either punishment, by way of time, by way of just to show dominance, and all this will happen. Now, of course, use of stimulation with technology. Stimulation with technology could be digital. It could be you are using it, sexual interaction through digital technology or via digital technology or with it. You are just using a technology to initiate sexual. And this could start by way of technology-mediated sexual interaction, sex texting, app texting, and cyber sex. Now, as healthcare, for those that are healthcare provider within the audience, so you need to be very cautious and careful. When somebody said you are taking history around sexual practices, have you ever had sex? It's not enough as a question now, because then we will think, oh, it's just penile vaginal sex. So if somebody said I had sex, then, I mean, based on what I've just shared, the first 10 slides, we will need to really probe to find out, to be able to do your proper risk profiling. Now, this is an example of sexual networking that could happen and the public health implication. It could be a direct contact. The direct contact could be mouth to genital, mouth to oral, mouth to anal, what known as anilingus. It could be sequential. That is, it is not happening at the same time. And it could be a combination of both penetrative and non-penetrative. But what is important for one to really appreciate the sexual networking issue from public health perspective is that when you have sex with someone, you're having sex with someone they have had sex with, and with someone everyone had sex with, and with everyone they have had sex with. And this continue infinitum. So if you inadvertently have sex with somebody, you are having sex with multiplicity of that person's sexual history by way of implication. And this has to be known for those that are engaging in that activity, and also when you are trying to do a risk profile. Now, I'm just showing an example from the context of substance abuse. There are about 11 different definitions of what is sexual risk behavior. Sexual risk behavior is not just enough to say, oh, you didn't use condom or barrier method. It could be in form of the last time you have had sex. It could be in form of partner you have had sex with. It could be the age at which you have had sex with. It could be in terms of the partner, the risk of the partner that you have engaged with. For example, if somebody has sex with a sex worker, now it is going to be a multiplicity of other factors because that person is engaging in sex from the perspective of business. Now, this is a factor, a risk factor conceptual framework that there are three key things to consider here. Sexual activity in terms of age, and then, of course, partner, and then the risk from STI, HIV, whether there are other legal issues from it. Then the other thing that is also important to note is the psychological consequence of people in initiating sex. Anyone that has a mental health issue, they could have what we call sexual inhibition. And when they have that sexual inhibition, engaging in sexual risk behavior may be a subtle way to really look in terms of the background personality issue, mental health issue out of it. So group sex is not something that is out of ordinary. There are publications out of it, and it has been shown to increase HIV risk and, of course, other sexually transmitted infections. This is a publication as far back as 2016. Now, I will now go to the other half before I present the study. Human papillomavirus infection is a sexually transmitted infection that is chiefly transmitted through unprotected, largely penetrative sexual activity. But it is also possible to acquire this infection from non-penetrative. And from the diagram here, 13 of them have potential to cause cancer. What do? They have predilection to breach mucocutaneous surfaces. And these mucocutaneous surfaces could be transformation zone at the neck of the womb, at the cervix. It could be in the mouth. It could be in the throat. And of course, it could also be in the anal vag. So this is the natural history for those of us that are in science or public health that we are familiar with. When you acquire HPV infection, the infection stands there for so many times. There's bruises of the epithelial lining. The virus gets incorporated into the cells. And if nothing is done, this cell undergo conformational changes. I don't want, because this is a public lecture, I don't want to go into too much details. And then, of course, if nothing is done after some period, this could lead to abnormal development of cells, and this could lead to cancer. However, when cancer happens, what is important is that there is a failure of opportunity to screen. Now, just this month, although this paper was accepted in February, 2 months ago, the International Papillomavirus Society Policy Committee came up and put up some experts together to review the natural history of cervical human papillomavirus infection. And they are saying that when you found out that a woman has HPV detected, you should not say HPV infected, because the HPV testing that you are doing, you are only trying to identify DNA of the virus. You don't know whether it's a live virus that you are picking or the DNA of the virus. So they now updated it to show that there are 5 possibilities when HPV is detected, either in the cervix, in the mouth, in the anal, in the penile, as I will show from our data that we collected in Ibadan. It could be a new infection. It could be a reinfection. It could be a reactivation of a non-detectable infection. That is, somebody may have had that infection, but it's not detected. That means that patient has latent infection. It could be a redetection of a low-level chronic infection. Again, if somebody said, I'm HPV positive, I'll be interested in the platform they use, because they all have different sensitivity and different specificity. That is the ability to detect HPV based on their viral load. And then it could be a deposition of HPV DNA if the person just had sex. It could be the DNA of the HPV of the partner that you are looking at, and it could be an auto inoculation. Say, for example, if I put my hand in my genital, I go to the loo, I didn't wash my hand, I put it in the mouth, and I go out to go and do oral HPV test, and they found HPV in my mouth. They can't say that I have oral HPV infection. They could say I have HPV positive in my oral sample, or is detected, because of these 5 issues that has now been resolved. So they came up with this to say that there is an interplay between HPV infection and HPV detected. And they advise, particularly clinicians, from the perspective of this new understanding that we should be telling our people HPV positive or HPV detected, not HPV infected, because this could cause issue of family fracture, it could cause problem when in fact the person did not have infection, he just has HPV DNA. So HPV is very common. 8 out of every 10 people that are sexually experienced will have it in their lifetime. And relative to other sexually transmitted infection, HPV is actually more effective than HIV. And of course, irrespective of other potential discriminatory factors, these are the other things that could be associated with it, the type of sexual behavior you engage with, your lifestyle, and there are some biological predilections. Say, for example, if you have HIV positive, you are more likely to have HPV detected. If you have immunosuppression, and then, of course, somebody that is also engaging in steroid. Now, this is the global prevalence. HPV infection is more common in young population less than 25 years, and also menopausal women. And there is a dip between 25 and 50 years. Now, persistence of this infection will lead to cancer in, well, publication, some publication will say 99% cervix or 100%. I'm aware one of my colleagues is working on cervical cancer that are not caused by HPV. That is Professor Akiyemi Ojeshino. That is his main focus. Even though it's very rare condition, we still need to know those less than 1%. Of course, anal cancer, 8 out of anal cancer, 88% vaginal cancer, and then of course, head and neck cancer. Here is talking about oral, the throat, and of course, the penis, so also penile cancer, and of course, vulvar cancer. All these cancers account for 5% of all cancers. Now, when you compare the burden of HPV relative to other infection-associated cancer globally, HPV follows Helicobacter that is associated with stomach, cancer of the stomach. And then, of course, if you look at it by way of region, HPV tends to have higher burden in Africa relative to other regions. And then, of course, within Africa, if we look at infections associated, cancer cases, you can see that HPV-associated cancer is more than other infection in Africa. Now, if we look at it by region now, East Africa has the highest, 56,000 cases relative to Helicobacter that cause gastric cancer, cancer of the stomach. And then in West Africa, 34,000 attributable infections associated with cancer. And then, of course, followed by Southern Africa, 16,000 cases. And then, of course, Central Africa had the least. Now, this is a paper, this is an old paper published in 2018, but it's still reflecting the same to show that Africa, the population attributable factor of HPV is very high in Africa and is higher in female than male. Now, this is an interesting paper that was published some years ago to show a trend of increasing oral cancer in people. It was published in Globacon database in 2012, and data from France, another European country, are showing increasing head and neck cancer. And these are all associated with increasing engagement in unprotected oral sex. And a lot of celebrities have been coming forward to also attribute this. And it's something that we will need to take note. Now, HIV increases the burden of HPV-associated cancer. This is a scoping review published in 2020 to show that the risk across all the 5 cancers ranges between 2 to 22% relative to those that are not HIV positive. Now, we did a search of evidence in Nigeria recently by our group in Ibadan, and we review all publications. Do we have evidence in country? And we found out that 48 publications on HPV epidemiology, 59 on vaccine, and then 78 on HPV-related disease. But I must say upfront here, most of these data are facility-based. Now, what is interesting is that there is a huge gap in research on HPV in Nigeria. Most of our publication, almost 80–90% of it, is on prevalence, where little or no information is available to us to be able to generalize, to understand the association between the infection and the disease. And most of these, like I said, are publications that are in hospital-based. Only very few are population-based. Now, you can't talk about HPV infection in Nigeria without talking about a medical study. This was a study published, done in the early 2000s, and I'm happy Professor Mbodun is here. It's part of the group. I think this paper was led by Professor Thomas, one of our teachers. They looked at the prevalence, and the prevalence they found is that prevalence of HPV, which they standardized by age, ranged between 24 to 26%, with an overall average of 26.3%. Now, NOAC is in University of Maryland. It did look at men who have sex with men, and the prevalence of high-risk HPV in them is 7 out of every 10 of them. That is in their anal cavity. And of course, having HPV is virtually all of them, 92%. Now, the FWACS study that was led by Lindeni and Professor Adewale, they still looked at specific associated cancer and the burden in Africa, using data from 3 countries, Ghana, Nigeria, and South Africa. And they did show that HPV 16, 18, and 35 is associated with invasive disease. And of course, they also disaggregate their data by the histological type, whether it's invasive, whether it's squamous, whether it's adenocarcinoma. Now, are the sexual behavior or practices changing? That is the reality we need to know this afternoon. Now, this study, one of the largest sexual behavior study in the world, that is called National Survey of Sexual Attitude and Lifestyle, NATSAL, that is done in UK every 10 years. Their sample size at range between 12,000. The one they just completed in 2024 post-COVID, it's 19,000, and they are undergoing analysis now. And they do show that sexual behavior is indeed changing. And you can see from NATSA 1 to NATSA 2, the proportion of those that had ever performed oral sex or ever engaged in anal sex, irrespective of their sexual orientation, is increasing. And you can see oral sex is increasing by 10 digits, and of course, that of anal sex too. Now, if you compare between 1990 and 2010, what they were reporting in 1990 is that 1 in 10 women had engaged in oral sex. And now, 2010 to 2012, they are saying 1 in 5. And you can also see that I don't know what the 2024 data will say. Now, the similar thing happens in the US, although the proportion, you can see here, that between the survey done 2000 to 2029, within 10 years, it has increased by almost 21%. There is almost a similar pattern between male and female there. So there is incontrovertible evidence that sexual behavior are changing globally. And there are plenty of data on that. And sexual behavior has been linked with oral and anal, has been linked with HPV-associated cancer if it persists. And the HPV acquisition or the reinfection persists. And they found out that what is also flaring it is engaging in other sexual activity, like oral and anal. So as part of the prelude to Shini's study, we did a systematic review published in 2019, where we reviewed over 100 studies in Africa. And we found out that a lot of young people are engaging in oral and anal sex. Unfortunately, one of the limitations of this publication is that only 4 out of 103 studies reviewed actually defined their oral and anal sex by risk profiling. When you say oral sex, they will ask, did you give oral sex to your partner? Or did you receive from your partner? That's how you'll be able to understand the risk associated with their action. But most of us, particularly studies from Nigeria, with all due respect, they were just asking, have you had oral sex? And as I will prove later, many people that were asked in another study, even though it's in Southern Africa, they asked them whether they've ever engaged in anal sex or vaginal sex, and they could not decipher the difference between anal sex and vaginal sex by just asking that word without attaching an operational definition. So this is the outcome. If you look at it here, you can see the one that is interesting, the triangle one. You can see they are very sparse. Those are the studies out of the 103 that disaggregated by whether insertive or whether given or received. You can see the majority of people just ask, have you had oral sex? What does that mean? It means nothing, because you don't know the role the person played. So you cannot link it to health. And then, of course, in terms of anal, you can guess from anal if you ask a woman, but now you cannot guess because if that woman is engaged in same-sex relationship, she may have had what is called anolingus, where if he's a female partner, could have used her tongue to touch her anal vag, and she could also have used toy or used other artificial things to touch. So really, if you ask her, have you had anal sex? You say yes. But if you don't ask, what role did you play? You will not be able to know the health benefit. Now, similar studies were done in Democratic Republic of Congo called Okapi study. They did also show, apologies, it's a bit blood, but they did show that a third of women, young women that were asked, are engaging in anal sex, penetrative anal sex with their male partner. So again, some studies have shown that why people are doing this is to protect their virginity, because young people believe that a lot of religion attach social sacredness to breaking their virginity. So a lot of people are also engaging in anal, what we call dry sex, and they do not know the benefit of engaging it. So that is what I call condomless sex. So when people say they engage in sex, you must also ask them, was it protective? What protection did you use? If somebody says, oh, I protected myself, it's not enough. You need to know what type of protection, because the protection using barrier method is not synonymous with that of HIV, which I also proved with some data from Sheeny study. So what is the Sheeny study? Sheeny study is sexual behavior and HPV infection in Nigeria, in Ibadan. It has 5 objectives. The first is that we want to understand what is sexual behavior across population group. Adolescents, adults, and then of course, those that engage in sex for business, female sex workers. And then we also want to know what drives their attitude, what drives their motivation. Are they aware of potential health risk? Do they understand the stigma associated with it? Before we now went into the epidemiology. Under epidemiology, we looked at all these prevalence for each of the sites, factors for each of the sites. Then we also ask a question. If you have HPV detected at the site, is it strong enough for you to look at other sites? So this is the conceptual framework we use. The conceptual framework, the qualitative look at understanding the sexual behavior from the perspective of penetrative and non-penetrative sex. And then, of course, like I mentioned, auto-inoculation could happen. So you could acquire HPV infection without necessarily engaging in any form of sex. So this study was a mixed method study that included a qualitative study and a household population-based study where we work with National Population Commission, Ministry of Urban and Regional Planning of your state. And then, of course, we engage in focus group discussion, in-depth interviews, and then, of course, we went into the community. So we used 2 local governments for the quantitative study, and for the qualitative study, we used 5 local governments. And our conceptual model is to use what we call socio-ecological model. We look at sexual behavior from the individual or intrapersonal perspective, interpersonal perspective, what is the effect of the organization or community, and then, of course, do they have insight into the environment and the policy implication of the health risk associated with their behavior. And of course, this is the breakdown. I will, you following all the rules of qualitative, it has to be purposive. Brothels were used to recruit sex workers. We engaged with about 30 brothels in Ibadan. And then the general population we recruited from tertiary institutions, vocational centers, markets, and then, of course, people in their houses. Now, for the quantitative, we conducted a face-to-face interview at the clinic located within a community in Ibadan. We did a clinical examination, a gender-matched nurse, that is a male nurse, examine a male participant, a female nurse examine a female participant. And we collected oral, cervical, vulvar, anal, and penile samples. And all these samples were maintained in a -80 freezer. In fact, they are still there till now. And they were shipped to Catalan Institute of Oncology in Spain. And then, of course, for HPV genotyping. And we did a robust analysis using hierarchical modeling. That is, what is the effect of sociodemographics, what is the effect of the behavior, what is the effect of some biological. Two things we take on that biological. If you have HPV in one place, can you have it as a risk factor? If you have HIV, and we also ask, and if you have also been treated with HPV, with STI before. This is what we did. We selected community that we're going to use. We broke it down into enumeration area with the support of National Population Commission. And we selected these enumeration areas by what we call population probability proportion to size. And then we did a census of all the houses. We list all these houses. And then, of course, this form our frame where we now randomly pick. And these people are now invited to the clinic. Now, when they get to the clinic, 5 activities happen. We took consent, we did interview, we examined them, we did sample collection, and then we gave them opportunity for follow-up because we detected some of them have hypertension and some other conditions. Now, for the brothels, it's a bit interesting. We couldn't set up clinic for them. So we negotiated with them, and they agreed that we could use their room as mobile clinic. So in some facility, we used their room and we paid for it. And then, of course, we ran the same. So we kind of used what we call a mobile clinic here. So all houses were listed. This is our numbers, and this is one of our team members listing the house. We had a very robust data collection tool, carefully designed, and we collected 9 section questions. I think it's about 45 pages. Where we got their information about their lifestyle, alcohol use, smoking, local stimulants, illicit drug use, knowledge about HPV, type of sexual relationship they have had, whether they engage in masturbation, circumcision, intravaginal practices, their medical history we took, and we did clinical examination for them. And I must thank Professor Akin Adebi from medicine, because by the time we're doing this study, that was when Red Cap is just coming on board, and he really took up the challenge for us to be able to host I think sexual behavior study is one of the early studies that were hosted on Red Cap College of Medicine. Thank you, sir. So this is the breakdown of what I have described. In total, we approach nearly 2,000 people. And this is the level of random selection. We broke them down into adolescent adults and then adults. Adolescent adults are people that are between 18 to 24, and then adults are 25 and above to 45. Now, this is just the breakdown in Ibadan North. But what is important on the right, the white, that is what I wanted to focus on, is the cadastral map. We also did, we used the Garmin SPA to get the coordinates of those houses, and we listed each house. So one of the things we could do is to do a special analysis to look at the spread of HPV, which we have not even touched at all. But this is the map drawn by the Oyo State Ministry of Urban and Regional Planning. This is for Akinyele. In Akinyele, we recruited in both Moniya and Shasha because we could not get enough sample size. Now, for the sex workers, we listed 344 of them, like I said, from 5 local governments, and eventually only 4 declined, and 315 of them participated and submitted. Participation is defined as participating in the interview, submitting all the biological samples. Now, this is the conceptual framework by which we now analyzed our data and presented. So we have a distant factor of social demographics, intermediate factor of type of sexual behavior they engage, culture, other related factors, whether they use barrier method, and whether in fact we detected HPV in one side. And then, of course, we did a risk factor analysis using hierarchical modeling. So what are the key findings? This is the second publication from the work. Here, what we found is that the awareness and source of information is different between young people and adult people. And motivation to engage in non-penile vaginal sex differs between young people and older people. And that's why I depicted with this cartoon here. What are other words for sexual act? What you are going to respond will depend on many things. What is in your mind, your age, and something. Some of them are saying love making, intimacy, copulation. And now what is interesting is that there are slangs for this sexual behavior. And there are different slangs. Slangs for when a man is giving oral sex, when a woman is giving it, when a woman is receiving it, when a man is giving it. But of note is that young people are using this slang to kind of covertly discuss sexual behavior activities without the knowledge of their parents or guardian. So one of them said, oh, I was discussing with my friend over the phone, and I said, I licked that plate. And my mom came to me and said, I've told you, if you need more food, you should ask. Oh, he said, I'm happy that she did not know that I was talking about sex, because I was afraid that she heard what I was saying. And then, of course, the sex worker says they have slang they also use for sex to profile customers so that they will know whether they are first-timers, so that they can bill them heavily. And those people, they call them mugu. And then, of course, those that come regularly, they know by the time they speak the language to them. Now, there are other studies. That's just an example. Now, what are the key findings from our community? Quantitative study. Are there gender difference in oral sex and masturbation? There are. Oral sex tends to be more reported by men than women, and in fact, it's 3 times more likely for a man to have reported have engaged in oral sex than a woman. And then, of course, to have received is also more likely. Now, this is a paper that we have just submitted. We're looking at unveiling masturbatory sexual behavior. We're looking into insight. Here also, self-masturbation is less common. I mean, 66 out of 10 people have engaged in self-masturbation compared to mutual masturbation on about 84%. And it's more common in male than female. Now, in terms of factors associated with it, self-masturbation is more common among people that are skilled, people that have mobile phone, people that engage in alcohol, while mutual masturbation is more common in other ethnicity group compared to Yoruba. And then, of course, it's less likely where you live is also a function. Living in rural area protects against engaging in masturbation. And then, of course, ever engaged in sex is a risk factor. Now, what about risk factor of high risk and HPV in males and females? And how does it differ between age and then, of course, the role of HPV 35 that is not in any of the candidate HPV vaccine now? Now, what is important here is that I want you to be looking at the lower side. This is cervical. If you look at the red bar, the red triangle, these are the high-risk one, the 13 high-risk one. If you look at it here, HPV 35 is the commonest in the cervical. And then, of course, HPV 42. But for purpose of this presentation, I'll focus on high-risk HPV alone. Now, if you look at vulva in women, HPV 35 most common. If you look at anal, HPV 52 followed by HPV 35. And if you look at oral in women, HPV 51 followed by HPV 35 and 39. So in effect, in women in general population, HPV 35 is common. HPV 16 is there, but it's just that's the commonest. Now, if you look at female sex worker, the same pattern. In the cervix, HPV 35 is the commonest. In the vulva, HPV 35 is the commonest. In anal, HPV 35 is the commonest. And then, of course, oral, HPV 35 is commonest. The question that we ask ourselves, I will post it shortly. Now, in terms of the prevalence across sites, I'll just use 2 sites here as an example. If you look at oral, and if you look at the cervix. Now, if you look at any high risk, that is the second row, you see here that 4 out of every 10 women had at least one high risk HPV, whereas 1 out of every 10 has oral high risk HPV. The same pattern but higher higher prevalence among female sex workers. That is now 1 in 5. And then, of course, above 1 in 10 for oral for female sex workers. Now, how can you profile people when they present in the clinic? What is important here on this table as a key message is that you need to ask questions about number of partners. Women who have women who have higher sexual partner are more likely to have HPV in the cervix, and then, of course, HPV in the vulva. But what is important most is the biological factor. If you have HPV in one side, it's a risk factor for HPV in another side. Now, if you look at men, we also collected data on men. Now, HPV 35 is the commonest, again, in penile HPV. And I must say here, over 98% of men that we examined were circumcised. And of course, HPV 6 is the lowest risk in penile. The same thing pattern for anal HPV in them 35, and then of course 39 in oral, followed by 35. And in terms of the risk factor too, but you can see that men tend to have lower risk. And it stands to reason that men like to receive based on prevalence I've shared with respect to oral sex. So maybe they don't like to, the proportion of them that give oral sex is lower than that of female. But in terms of penile HPV, 1 in 3 high risk have penile HPV, 1 in 4 had anal, and then of course, less than 1 in 20 have oral HPV, high risk. The same pattern, if you have HPV in one side, is a risk factor for HPV in another side. Now, number of lifetime partner here tend to be protective. We do not know whether it is due to noise. We are going to explore that further. But what is important is that when you have other sexual partner, the odds are higher for oral HPV. Now, when you have HPV in one side, it could be a risk factor for another side. And now, like I talked about the difference between using HPV infection, HPV detection, HPV positive. It could be due to the concept of what we call viral shedding, particularly in female. When a woman goes to the bathroom and clean, if a woman cleans front and back, it's more likely there is secretions, vaginal secretion, that could be into the anal vag, and then of course the DNA can be detected. That's viral shedding, and it will occur synchronously. What we're also trying to prove through epigenetic analysis, which I'll talk in a few minutes, is that it will happen de novo. That is, it will happen together with a particular genetic predilection. Now, this is, again, looking at concordance. Of importance here is to show that cervical, it stands to reason, there is higher concordance of having this any high risk in the cervix and vulva. It's across all anatomic sites. If you have it in one site, you are more likely to have certain percentage of people that will have. So the lesson here is that if a woman is positive to cervical HPV or oral HPV, please check other sites before you tell her she's fine. Now, the same pattern for female sex workers, the same pattern for male in the general population, but at a lower proportion. And it stands to reason because the organs are far apart. The penile shaft is not as close between the cervix and the anal in female. Now, what are the published products? I've shared some. Part of this data was used for my PhD defense, and these are my examiners in the middle is Susanna, one of my co-supervisors, and that's my workstation in London. Now, I've talked about oral HPV terminologies that were published. This paper was published where we look at the prevalence in sex workers, where we look at prevalence of orogenital and anal HPV in women. And then, of course, this is the first paper on penile, anal, and oral HPV in men. I think it's the first paper to our knowledge in West Africa, and possibly the largest data in sub-Saharan Africa till date. And then, of course, this paper came out, I think, last month. We published this with 2 of our residents, that's Dr. Yuridi and Dr. Caleb. where we look at relative contribution of lifestyle, behavioral, and biological factor for cervical human papillomavirus infection. Here, we're saying that it's more likely that the risk of having HPV, cervical HPV, is cumulative rather than individual. And we make use of QGC modeling to prove this. And this was published in Virus. Well, this paper has been partly accepted. We are looking at prevalence of oral in +1. I think it should come out any moment from now. Dr. Fowotade and the group, we look at our stored sample. This is one of the post products. She's leading this. This is ready, and I think it's been submitted, where we look at oral HPV and Epstein-Barr virus. Epstein-Barr virus potentiates persistence and is a co-infection. So we look at co-infection and we run some modeling. And one of the things we found out is that being HIV positive, having HPV in other sites could increase the odds of oral Epstein-Barr virus. And of course, we have gone epigenetics, looking at the environment. Is it possible to predict persistence if you know the HPV? This is a catalyzer grant that we got with Northwestern, and I think virtually all the team members with our seniors are here, Professor Ogubi and Professor Adewale, where this was presented, I think, this week at the American Cancer Association conference, where we showed that hypermethylation of non-classical HLA gene may serve as biomarker for identifying women at risk of persistence, even from a cross-sectional study. One of our project staff who has successfully defended a PhD today, I can confidently call her Dr. Olushola Ibrahim. She led a paper on qualitative exploration of perceived risk, motivation, and risk management strategy among brothel-based female sex workers. The paper is submitted. And then, of course, this is second epigenetic data that we also provided. Here, we identify methylation patterns that we can use to predict oral HPV samples, to predict whether they could develop oral cancer in future, so that you don't have to wait for 6 months to repeat. We did this as part of our pre-study, but we used the Shini samples to develop this heat map. Now, we have samples, and we have lifted the bar on our sample. We have, like mentioned by the moderator, we have over 20,000 samples. And this sample is now available. We're ready to collaborate. And I think people can come in. People are already using the data. So, but it's important for us to know what are the drivers of cancer in sub-Saharan Africa. The prevalence and incidence have shown that. What I've not shown, because of the timing, is interpretation of sexual behavior and health-seeking behavior, how it affects acquisition or risk of HPV infection. But it's important to know from literature there is a poor understanding of connection between sexual behavior and health risk associated with it. It is also important to know that apart from Shini study, most of these sexual behavior study that we reviewed in Nigeria were not well designed. In fact, many of them were not, they did talk about their sample size, we do not know the power. Sometimes we do not even know the setting. And we also do not know how the information were collected. Was it a face-to-face interview? Did they use a CASI method? Did they use by online? Some of the people are silent. So we're saying that it's important to borrow a lead from NATSAL and Hans, where they did a proper study for us to be able to have a good data system. But what is also important that we should begin, as we unhat this information, this epidemiological information, we have to develop our health system. Now, when people are aware that they need to go for screening, they need to go for tests, are we ready to absorb this? So it's important that to know all this. But I must say that vaccination is now very important. And Nigeria has come up with a very good message. We vaccinated over 12 million people, and that's the largest in the world. And we have also started the screening. So what are the emerging science from Shini study? Our team is has won several grants, and I will use these 4 grants to show it. We got an R01 grant when we partnered with Northwestern University, and we are currently working with 13 teaching hospitals in Nigeria to learn the natural history of oral HPV infection, pre-cancer, and cancer in men, because these are not well developed in the literature globally. So it will be a novel thing. And one of the novel equipment we are using is Velscope that looks like a colposcope, where you can detect pre-cancer lesion. And then, of course, we are going to possibly develop an atlas out of that. Then, of course, we also got looking at synchronous effect between the cervix and the anal. That's the epigenetics of anal HPV, cervical high-risk HPV. We are currently performing an implementation science study with our colleagues in Northwestern, and also there's a site in Jos where we're looking at the effect of self-sampling for cervical cancer among people living with HIV. And we do see and treat. They get treated the same day. We get our HPV DNA test result within 1 to 2 hours, and then they do colposcopy. They have thermal ablation or LEAP almost immediately. And recently, I think about December, we won another grant by European Union, where we will be evaluating HPV vaccination in 2 countries in Africa. That's Nigeria and Tanzania. In Nigeria, we'll be working in Jigawa, Nasarawa, and Osun State, where we will learn in terms of, and by the way, all these states were picked based on their DP3 coverage. And this is going to be a 4.5-year grant that we will run with London School of Hygiene and Tropical Medicine, Catalan Institute of Oncology in Spain, and then the National Research Institute in Tanzania. So what are the scientific implications? We need to have a better understanding of sexual behavior. So that's the first message I want to push forward. The second is that we have provided evidence that multiple HPV infection is possible. HPV 35 is increasingly reported. In fact, NCI has put up an advert, and they are collecting biological samples, including cancer sample in African America. And to date, we have presented our work, 14 abstracts. We have about 13 published papers. 3 of the MPH students are currently using our data. Data is still available for anybody that wants to use it. You just need to write a letter to the group, and you make a presentation and we'll sign. And then our research coordinator is also using it for, so this is the publication. And this is Olami Posi, where she's doing a post-field presentation, doctoral presentation, where she is trying to use the Shini study to develop a machine learning model to predict cervical and anal HPV infection in sexually active women. And she has successfully done a post-field presentation. She's waiting for the FICS. So at the policy level, when we are writing our policy and we are discussing the legal framework of our country, we have to be explicit so that people will not get confused at the point of implementation. Are we going to use our legal framework? Are we going to use science? Are we going to base it on moral or religion or culture? We need to make a decision as a country. The second is that the NDHS, I saw thousands of publications on sexual risk behavior in Nigeria. All were based largely on penile vaginal sex. Only very few studies were on key population, that is the IBBS survey. And the first 2 also did not classically characterize what the oral sex by definition and anal sex. So we can say we do not have national data that we can use for policy if we compare ourselves to UK and US. Now, what will be the policy on group sex? Because if somebody said, oh, 3 people had sex with me, the first thing we'll say, go and lock them up. But we ask whether it's consensual or not. Because if it's consensual, then that means to them, it's not a crime, but to them. But we do not know. I don't even know what is the legal framework in Nigeria about group sex. So the country should also make an aggressive plan and thumbs up to the leadership of Federal Ministry of Health Nigeria. We have vaccinated 12 million. We are beginning to work very well, and of course we have prevention programs. Now I will just end with these 2-3 slides to say that a recent publication last year did look at HPV-associated invasive cervical cancer, published in Lancet, and they still show that 16-18 is commonest, but 35 is associated. So other high risk are associated. And that's why, if as a country we want to make up our mind, we have to pay attention to the genotype if we want to have a policy-driven intervention for the country. Because it's not just enough for us to say we've done VIA. VIA is good in where there's nothing, but you need to also know the genotype that is associated. Now, we also have a small effort here in Ibadan, commissioned by MSD, where we are about to publish it. We look at 52 publications in Nigeria, and we did show that globally so far from the papers in Nigeria, 40% of people have any HPV in the cervix, and 27, nearly above 1 in 4 women have high-risk HPV. And then this is the genotype, pooled prevalence of genotype. Please, we have not published it. And we also disaggregated the HPV by whether they could cover bivalent, quadrivalent, non-valent. This is for our policymaker to take notes, to say that it is good that Nigeria adopted quadrivalent because we are covering more population. But if you have money, why not non-valent? So again, further confirming what I've just said about that. So what are the recommendations? We have started. This is awareness creation. We should talk to our wards, our kids. Sexual health education program is important. We need to strengthen our sexual and health policy. A parent should not be shy to talk to his or her kids about sexual activity. And then, of course, the country should drive towards a national data on sexual behavior. And we need to have a robust cancer control plan that will include HPV-associated cancer. Yes, the country has started very well by establishing NICRAT. When I think the process started when Professor Adjunct was minister. And incidentally now, as Providence will have it, he's now been selected to head the National Task Force for Cervical Cancer Elimination. And the committee is really working, and I think we have over 10 subcommittees. And of course, effort is being made to ensure that HPV vaccination is universally put on the table. Well, this is just to show the modeling that is also presented by way of type of vaccination. If we focus, if we invest heavily in vaccination, and we could achieve 80% vaccine coverage, we can actually get, we can eliminate cervical cancer in Nigeria as an example. So I will want to end with this controversy of 1995. When there is an altercation, what we call the state affair between President Bill Clinton and Lewinsky, the question is, they were using what in terms of foreplay, oral sex, masturbation, sexual act, and contact. The president's story is that I had sexual contact, and he believes it's not sexual intercourse. So from what you have listened, make up your mind and go back and read the story. I will conclude by saying that despite rising burden of HPV-associated cancer in Africa, there is limited information on the relationship between different sexual behavior and risk of HPV-associated cancer. We have limited studies on non-penile vaginal sex, like I've emphasized. We need to collaborate, particularly getting population estimates, where we can make generalizable statements about sexual behavior and the risk, and can use this to project. So Nigeria is on that trajectory. We have started by investing wisely in a very cheap, easy to do prevention method, which is vaccination. Because if you achieve herd immunity, we can actually fast track our elimination agenda. And I believe that all the agencies of government are doing that. I want to acknowledge openly the University of Ibadan, who provided capacity building scholarship for me, revitalization fund between 2014 and 2029. These were made open to all the lecturer one and senior lecturer then when Professor Adewale was vice chancellor. And I want to thank his successor because when I had some hiccups, he supported me to ensure that I completed the program. And of course, the Department of Academic Planning, University of Ibadan. The provost of the College of Medicine, the leadership of London School of Hygiene and Tropical Medicine, so many collaborators and mentors, the Oyo State government, because we wrote them, and particularly Dr. Muideen and Bumi Ainde, they were medical officers in local government that time, they supported me. And then of course, IAMRAT rector, when I had issue of space, I was gladly accepted to be part of the team. And my department for allowing me to go on that journey to England for 4 years to learn new science. So these are some of the pictures. We had advocacy meetings with development organization, social development committee at the local government level, because you cannot do it if you don't enter the community properly. We engage, they advised us. Of course, we had visitation to learn what we are doing, visitation to come to probe what we are doing, because this is the boss of the university. To be sure, the money I was requesting. I remember when I requested for 150,000 euro to ship samples abroad. He could not believe it. He said he wants to come and see. And in fact, the Deputy Vice Chancellor Academics was also here. And this is World Korea giving us award here as the largest, the customer with the largest sample they ever shipped from Nigeria, because they shipped over 10,000 samples at a time. This was us as brothels and the musicians that play to encourage them, because we have to be there with them. These are our team to show our activities. And then, of course, Professor Bakari was one of my local mentors. I want to also acknowledge Professor Jegede. He also was my mentor in terms of social science. And then, of course, we had advisor meetings, online, physical. We also take advantage. This was at IPVS in 2017. And when I was at Barcelona to run the sample, these are the team that put me through all the HPV genotyping that we did there. So the sun is on the horizon. I'm sure you will have been hearing about HPV Consortium College of Medicine. What we have been doing, members are here. I want to thank Professor Akiele, this Professor, I've mentioned Professor Gumbi, Dr. Daniel, and Paul Tade is here, and then of course, and the rest of, and then Dr. Adeumi. I cannot but mention others. So others are welcome. We're getting requests. We're talking to the general surgeon because we want to set up endoscopy with a group from Stanford University to start that soon. So we will officially launch it soon, and please stay tuned. Thank you for listening.
Thank you very much, so excellent delivery of your lectures. Perfect. May I call on Professor Akiyemi to handle the question and answer session? Over to you, Professor Akiyemi.
All right, thank you very much, Professor Morhason-Bello. I was waiting for a few seconds to be unmuted by the IT department. Again, this is a very, this is a groundbreaking work of almost a decade, about a decade. And many, many congratulations on this very rigorous and comprehensive work that ranges from epidemiology to genetics to epigenetics. Is real science, translational science, with implications for policy and practice. And of course, the HPV consortium has been an outcome, meaning the work continues. And of course, we grow to make great impact, not just in Africa, but globally. So I identify with it too. It's a very big congratulations, of course, to you and all our esteemed mentors and teachers who have guided you through the way. So time is fast spent, so we will not waste too much time, but just to entertain one or two comments or questions before we adjourn for today. Let me throw the first question from a neuroscience perspective. The brain is certainly the origin of behaviors. So you did mention that in the data you collected, you spoke about alcohol use as one of the risk factors in some of the participants. I wonder if you also had data, and I think you mentioned you had data on substance use. Were there any association between substance use and these high-risk behaviors in any of the subgroups, the subcohorts?
Thank you, Professor Akim. Yes. So we collected two data on that. I think that's section 3 or 4 of our data. So on their call, we actually went into detail. We used the WHO scale to know the number of pints that they take, and we estimate. That's one. The type of alcohol they take, we also asked them to describe it, and we categorized. Then in terms of illicit drug that they took, we asked a bunch of them, I think about 15 different types. I've asked one of my friends and classmates, that's Dr. Victor Makanjola. He's already working with us to do a secondary data analysis in terms of substance abuse use and high risk. But what we found is that smoking, alcohol, and illicit drug use are associated with anal HPV and also the risk of ever engaged in oral sex.
Thank you very much. I'm happy that Mark is already working with you. That's a very important aspect to explore in this very, very large work with the big team science. Yeah, well done. We would like to, if you have questions, can you please type them in the chat box? Certainly, we will request our esteemed mentors and leaders to make some closing remarks before I hand over to the director. But before that, if you have any very, very, very hot question, can you please put in the chat box? Or you may want to indicate by raise of hands. I'm trying to look at the participant list. If you think have a very hot question that should be, all right, Professor Falusima, you may please speak, ma. You may please unmute and make your comments.
Good morning.
Thank you.
All right.
Thank you very much. I am 7 o'clock or 8 o'clock here, and I'm happy that I'm privileged to listen to this really health transforming issues that Morhason has raised. I'm his neighbor in UCH, and I watched him at close quarters, dedicated, hardworking, and this is showing up that IAMRAT is really making the waves there now.
I'm very happy to say that you made 2 points which I'd like to comment on. The first one is I don't understand why you said that this is higher in menopausal area, because I expect that at menopausal these things are less active. I mean, we engage in lesser issues than those who are actively on and younger. That I will need an answer. The second is a comment to show that awareness. I'm happy that you showed that awareness is key. Awareness is very, very much important in prevention, especially in our society where very little education is there. You find that people think they know. They think they know, but the intricacies of what you are talking about, they really don't know. It's just hearsay and myths and things like that, and religion and all those things. I can claim it and all that. So I'm happy that you are thinking of this awareness as being very key. And if you do this, I'm sure it will reduce the burden of this disease in Nigeria. I mean, the HPV transmission going on in even besides the cohort of the group that is engaged in the work. In the universities, among even young adults in the high school, I think this awareness is so key.
All right. Thank you very much,
ma. Just to react to what you said, ma'am. Actually, we have started. I think maybe like three weeks ago, we had a roadshow where we engaged with to create awareness among members of staff, student union government of the University of Ibadan, and some resident doctors and young people. We had a roadshow where we moved from UCH, College of Medicine, to University of Ibadan, and we engaged on the way. In fact, the people in the secretariat were writing us to say they want us to come inside the secretariat to have a separate one. We also had a stopover in Bodija Market before we now went to Wole Soyinka Lecture Theatre, where we had a discussion there with the students of University of Ibadan. So we will continue to do that. Thank you.
All right, thank you very much, Ma. And thanks, Professor Morhason-Bello, for your response. Before we take comments from our various teams, leaders and teachers, Professor Akinka Tomibodun and our immediate past Honorable Minister of Health, Professor Adewale, we'll just take a quick comment from Professor Adidapo. I saw her hand up, so Ma, you have the floor, please.
Sorry, before they speak, I didn't answer Professor Falusi. He said, why is risk higher in menopause? Ma, things are changing. We have like 2 publications on that is now showing that sexual activity is actually increasing in perimenopausal and menopausal women, relative compared to before. And this is part of the changing sexual behavior. In fact, one of the publications that was that I reviewed recently showed that menopausal women tend to engage more in multiple sexual partnerships compared to younger population.
All right. May we please have Professor Adidapo?
Thank you so much. Good afternoon. I'm sorry I joined the meeting very late, but I was so impressed about the substance use aspect, and we know the issues with that. And from pharmacology, route of drug administration is very important. Long story short, are we looking at vaping, electronic nicotine delivery systems, considering this in the youth? And in fact, you'll be surprised that even in Nigeria, these are issues because of the global world we're in. Thank you very much.
Thank you, Ma. In fact, I didn't know that you are going to ask this. I think that could be another presentation. The type of drugs that we had, we listed, I think, about 15 of them, including shisha, alomo, and everything. And in fact, they added some during the qualitative, because what we did was did a sequential mixed method, where during the qualitative, we showed them what we know. And we're shocked that in other numbers of other additional things they mentioned. And we asked them whether they ever used it, whether they used it in the last 1 year, the last 6 months, the last 3 months. And the data are there. So for us to publish.
Okay, I see Dr. Adolphus showing more. Can you please make it very brief because of time before our leaders speak? Dr. Adolphus, please.
Thank you very much for a very good presentation. Just a quick question. Have you done any epidemiological studies in the African or Nigerian setting showing the relationship between oropharyngeal cancers and sexual behavior? Just to confirm the studies have been done abroad. Is there any African study or anything you can refer to?
Thank you, sir. Actually, that's our R01 grant that Professor Adewale, myself, Professor Ajisa, and Dr. Daniel are leading in Nigeria here. We're looking at the natural history. And so far, we have screened over 1,000 people where we have information whether they engage in oral sex or not. We are taking this, we are screening across 13 teaching hospitals in Southwest. And just last month, we are expanding to the north. One of our satellite recruitment sites is now Jos, and we may also expand to South-South. I think we're in the process of that. And I think we should be releasing 1 or 2 papers shortly, looking at the sexual behavior of people. And but before we'll be able to answer the question of connection between sexual behavior and oral cancer, so it may have to be towards the end or towards the later end of the study. But we are following them up. We take samples at every visit, both oral, cytology, and Dr. Adisa's team has a special microscope to do that. And we're doing quizzing. So we should be able to get that done soon.
Thank you.
All right. All right. Thank you very much.
There's this question here, considering the research population, right, and voluminous research question, and looking at the positive turnout of participants, what was the motivation for the participant? Proper community engagement. I must tell that I was supposed to do my PhD work for 3.5 years. But we ran into serious problem in terms of engaging the community, particularly the key population. Before they could trust me, I spent nothing less than 6 months. So community engagement alone took us almost 1 year. Almost 1 year. All those photographs I'm showing the social development committee sitting together. It's a lot of effort with special appreciation to medical officers of health at that time. Some of our colleagues were medical officers of health in the local government. Before they could organize that meeting, some of them take weeks. So I will suggest for us, for anyone that is intending to do a population-based study, you have to be patient. That's one. You also need to have the right team. Remember, I said we engage with National Population Commission, we engage with urban and regional planning, we engage with the leadership of local government. We have the photograph of all the chairmen of local government we work with. We have the I have the photograph of the owners of brothels. And for them, initially, they thought I was a secret service. So, I mean, so it's not something that we just say, oh, we're doing next week, and then we started. And then, of course, collaborating with other specialists that are experienced in community engagement programs.
All right. Right. Thank you very much, Professor Morhason-Bello. So now take comment, not closing comment. The director will take that closing comment, but from our esteemed leaders, Professor Omnibodun first, and we will still want our very esteemed immediate partner, even Minister of Health, to still give a fatherly word after Professor Omnibodun.
Thank you very much.
Yes,
I'm on, and I just want to congratulate Professor Morhason-Bello for this what I would describe as exquisite presentation. Bringing community work together with really intensive laboratory work and weaving a coherent narrative that tells a story about a very important problem that maybe came into consciousness fully just about 30 years ago when those who won the Nobel Prize for linking it to cervical cancer did their work. And I'm so happy that so many students, masters, PhD, are able to nest their work in the foundation that has been laid by Professor Morhason-Bello and his supervisors, Professor Adewale and Professor Deborah Watson James.
Jones, yes.
Yes, from the London School. And there's so much potential in what has been done so far. You mentioned something that struck me, and that was the enormous cost of transporting samples across for laboratory analysis. But I'm also glad because, I mean, in our interaction, you are making strenuous efforts to actually have laboratories here where molecular biology, cell biology, and all these other high-level laboratory analysis can be done. So I just want to encourage you to keep going. Bring, with the funding that you have, bring those facilities here, and maybe we can entice many more of our bright young people to stay here and do their work here and put our institution on the map. So congratulations once again. Thank you.
Thank you very much, sir, for those elegant comments. Very, very pertinent and really very impactful. So, Professor Adewale, sir, we would still like to hear your voice, sir. Yes, sir.
I actually felt that as an insider, that it would be an overkill to make comments after the wonderful presentation. And I think the only thing I can do is to align myself with Professor Omigbodun's comment and to also disclose that what Professor Morhason-Bello presented is the outcome of commitment, passion, institutional support, and overseas partnership, all combined to generate high-quality data that we are proud of. I'm also happy that there are efforts to domesticate the analytical part of this work locally. And the lab to do this is almost ready, and I'm sure that quite a number of this work can now be done locally. So congratulations to Professor Morhason-Bello and the team. And I said the sky is not the limit, but the beginning. Thank you.
Thank you very much, Sas, for this nugget of wisdom, which all of us on this platform have taken in and continue to deploy in a future pursuit. Thank you so much, Sas. So I'd now like to hand over to the director of the institute, Professor Kajai.
Hello, Doctor. Hello, Professor Akemi.
Yes, please.
Hello. Yeah.
Yes. Okay.
Please, yeah. It's like it's a common request from the participants that will the slides be shared to the participants if requested?
Let me respond to that.
Professor Morhason-Bello.
A lot of the content are very hot research data. I'm not sure anyway, Dr. Morhason-Bello can speak. They're very hot research data, some of which are not yet published. You may have to edit the slides before you can share them. I don't know, Prof. Morhason-Bello, you want to comment on that?
I think you have spoken because you are also an experienced researcher.
So I want to plead with our audience to maybe look out for the publications of many of these very hot research
We'll
data
share
sets.
all the published work. We'll
All
share.
right,
I'll
okay.
create a folder. Then we'll also share the screen because and they will also share the link to the presentation.
Right.
Put everything in a folder and send to Dr. Bakari.
All right.
Thank
So
you very
over
much.
to our director, ma'am, Professor Kiajayi.
Wow. I will say good afternoon to everyone again, and thank you very much for staying all through this lecture. I think it's worth it, and we want to thank our lecturer. But before I go, one of our older professor has actually put a comment, or she is asking for information, and that's Professor Emmanuel Otolorin. He says 12 million girls vaccinated against HPV is very much below the 80%. Check. Where is it? It's gone.
Well, I think I have the question. I thought
you have it.
Yeah,
okay.
I thought that I think Prof. Actually, Prof had been the chair of reproductive health technical working group before he retired from it. So Prof is an inside. I think he's just reminding me of what needs to be done to pass this. So he's saying 12 million girls vaccinated against HPV is very much below the 80% anticipated coverage. Who was financially responsible for the vaccine, FG or Gavi? With the withdrawal of USAID funding in general, will this affect vaccination coverage in Nigeria? And I think I can only share my own view. Professor Adewale is here, who chairs the National Task Force, and there is a subcommittee under him, which is vaccination, headed by, I think, Dr. Bakunawa. So I think it's more like an advice from him. But sir, I must say that 12 million that we did at the first round is the largest in the world. I recall at the last IPVS meeting in Edinburgh, where Professor Adewale and I attended, they were very, very ecstatic that Nigeria could do that, because that is more than the population of many African countries. So, and these were done just with 2 rounds. Now I'm aware that National Primary Care Development Agency is trying to routinize vaccination, meaning that people can now take it at any of the clinics, and I believe this will go. But of course, the USAID funding withdrawal is a general problem. And I think the minister is saying that the president has been briefed, and I think they've started releasing money to some extent, but we can only encourage them to do more.
Thank you very much. Maybe Professor Otolorin, just a word.
I don't know if Prof wants to say something about it.
Pardon me?
I don't know if he wants, I think Prof.
Yeah. Or he can give us a goodwill message and encourage the team and also those who participated in this lecture. Professor Otolorin, please. Just a brief one.
Well,
thank you, sir.
Thank you very much. I join others in congratulating Professor Morhason-Bello on this presentation. Great team, great work, and great presentation. I always like to take the next step towards the solution, implementation, taking research to practice and implementing recommendations. You are projected that we need to have 80% coverage to reduce prevalence by 50%. And just hoping that the government will take it up and ensure that funding is provided for the coverage to continue so that we can reach 80% coverage. I know that HPV vaccines are very expensive compared to measles vaccine or polio vaccine. I hope that the prices are coming down now with more people being vaccinated so that we can be an example to other countries in having very high coverage in order to reduce the prevalence of cervical intraepithelial neoplasia and cancer in our country. Thank you very much for the opportunity to listen and to learn more. Congratulations. Thank you.
Thank you very much, sir. We cannot end this lecture without some acknowledgements, and I want to start with Professor Isaac Adewale. I think he was one of the first people to join this lecture today. So we are very grateful for this and for your support to IAMRAT all the time. And I'm happy that one of your mentees is really doing great. I remember when I started my research, I was also mentored by you. My first publication was with Professor Adewale, and it was on cervical cancer. He so much supported me, and I thought he was looking at me continuing with cervical cancer, but that didn't happen. But I gained a lot from his mentoring. Thank you very much, sir. I will also acknowledge Professor Akinka. Akinka will be active, but I for your moving ONG forward. And then we have Professor Chinedu Babalola, the former VC of Christland University. He also joined us. But I also want to acknowledge Professor Fumi Olopade, who is also one of us in IAMRAT and also a friend and a great supporter of IAMRAT. She actually joined, despite the fact that she's a breast cancer guru, but I know cancer would also be an interest. But we're grateful for joining even at a time that is not so convenient at the other end. The CMAC, that's the Chairman Medical Advisory Committee of UCH, was also with us, and that's the person of Professor Additional Adewale. And we're very grateful for your time, for joining us. Our former directors with us, we are very grateful. Professor Falusi, you're always there with us, and I'm happy. Morhason-Bello is your neighbor. So you must have also impacted some of these good things to him, because you two, you were very, very hardworking, diligent, and forward-looking. I know if there are other former directors, you are all acknowledged. I tried to group the people that I could see attended this lecture, and I said that all stakeholders journey of bringing down HPV prevalence, cancer prevalence. And I've grouped them. We have our microbiologists and virologists experts with us. I saw Professor Kende and his team. Then we have our, I would say, the greatest supporter of Professor Morhason-Bello, and these are the O&G consultants and their team, the head of department and the whole team of the O&G departments. We are very grateful for honoring this lecture. Also, we have family physicians from UCH and outside UCH. We have the HPV consortium. Then we have the JAPEGO, where Professor Tolorin retired from, and we have them also represented. JAPEGO has done a lot of work amongst women, pregnant women, and so on. So I'm sure they must have benefited a lot from this lecture. Then we have epidemiologists, community medicine experts from the Public Health Faculty of Public Health in UCH and also other universities with us. And I want to thank the students, postgraduate students also joined this lecture. I'm sure apart from the technical knowledge, you have also learned a lot about how to conduct research, what translational research is all about, how to go about community engagement, community entry, and also what to do with whatever information you generate, and such that it can translate to policy. I think if there's no other thing that you are going home with today, that is something you should go home with. And even all of us that we are all researchers, we should continue to look forward to translating our research findings into policy to benefit the society and the communities. We also have we want to thank the study team, that's Professor Morhason-Bello's study team and the collaborators in Nigeria and internationally. I think you have done so well. And Professor Morhason-Bello has actually showcased the great work you are doing. And we really look forward to you coming back to share with us the findings of the other highly technical and also interesting papers that you're still going to write and analysis that you're going to do, because it's something that IAMRAT is very proud of, and we are very proud to have Professor Morhason-Bello in our midst. And we want to continue to assure Professor Morhason-Bello that the IAMRAT is there for you, and let us know how else we can help you better. And I'm happy you have a laboratory now. You know, we also want to have the extension of IAMRAT building. Maybe you want to consider this. If you have that grant, you can come and develop this and have more space for your work. But let me tell you, we are very proud of you. I also want to thank all the researchers from the international panels. I know I saw people from Rwanda, Dr. Folabi, who is also into vaccines. And I think I saw names from, I think, some other African countries. And from other African countries. Sorry, Bumi. Sorry, please. We have, all the international guests, we are very grateful to have you. And please always tune in the last Wednesday of the month for more exciting lectures. And I think all other people that I may not have mentioned, you are all recognized. And I pray that next month we'll all be here. And I can promise you that the next lecture for next month is really, really interesting. I want to thank my team, that is the IAMRAT staff. They've been very wonderful, and they've always been supportive. So thank you very much for your contributions. And I want to say that we all have a good evening. And we look forward to seeing you next month, Wednesday, the last Wednesday at 3 p.m. The next month is May.
Thank you.
Thank you very much and have a good evening.
All right.
Professor Morhason-Bello.
Thank you, Ma. Thank you.
Thank you very much. Thank you. We're very grateful.